Occupational English Test, Practice Test, Listening Test. This test has 3 parts. In each part you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have the time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for extract 1. This is an edubenchmark.com sample test paper. Extract 1. Questions 1 to 12. You hear a doctor in the A&E talking to a man who collapsed on the beach. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So, hello, Mr. Phelps. They tell me you had a fall?
Yeah, I was walking my dog on the beach near my house when I suddenly felt funny. And the next thing I know, I was on the ground. I was lucky, though, because somebody passing by called an ambulance.
Yes, you were lucky. So, did you notice any symptoms before you collapsed, like palpitations or chest pain?
No, I didn't notice anything particularly out of the ordinary.
It sounds like you lost consciousness. How long was that for, do you think?
I definitely did, but I'm not sure for how long. I don't think it was that long, maybe 30 seconds or so?
Yes, the witness who called the ambulance confirmed that. He also said that once you regained consciousness, you were not confused and you recovered quickly, which is a good sign. And you were walking on the beach, you said. So what were you doing immediately before you lost consciousness?
Well, as I said, I was with my dogs on the beach near my house. There are some sand dunes there, so it's not completely flat. I do remember that there was quite a steep incline, and I did dash after my dog as he disappeared over the top of the dune. I was worried he'd run away.
And did you sustain any injuries when you fell?
I must have banged my shoulder because it's hurting. I think I might have hit a rock, but I don't think I've hurt my head.
Yes, I can see some bruising on your right shoulder, but no signs of head injury. And in general, how often would you say you exercise?
Well, it's not as much as it used to be. I mean, I still try to take the dog out most days, but we used to go walking for at least an hour. Now it's more like 20 minutes maximum.
Okay, so duration has gone down quite drastically. And why is that?
I just don't have the strength. I get tired much faster than I used to, and often begin to feel short of breath.
And, Mr. Phelps, is this the first time you've experienced anything like this?
Well, I've had a few faints in the past. Not whilst walking the dogs, though. I had one when I was getting out of the shower. The room was really hot, and I started feeling nauseous, then blacked out.
So I can see that your blood pressure is elevated at 150 over 120, but your resting heart rate is fine at 65 BPM.
Well, I take medication for my blood pressure, so that is quite strange.
Do you take any other medications?
No other regular medication. No other types of drugs either. I mean, I used to drink a few pints of beer a week, but I stopped drinking a few years ago. I don't smoke either.
Well, that's great. So I'm going to order an ECG to see what's going on with your heart, and also a chest x-ray.
Okay, do you think I'll need surgery, Doctor?
Well, it's a bit early to tell, but it is certainly a possibility since you're experiencing symptoms that indicate there may be a serious problem with your heart. But first...
This is an edubenchmark.com sample test paper. Extract 2. Questions 13 to 24. You hear a GP talking to a man about back pain. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So, Thomas, it is nice to see you today, though perhaps not under these particular circumstances.
Yeah, I quite agree. But what can we do? I'm getting older. 50. Not a spring chicken anymore.
Well, none of us are anymore. So let's get to it. I see here that you made the appointment because of back pain.
Yeah, this morning I was lifting a TV out of my car when I suddenly felt this really awful back pain, and now it's been there ever since.
So where exactly is the back pain?
Well, as I said, the back pain started as soon as I lifted the television this morning. I felt a click and then a sharp pain in my lower back.
And you said the pain is still there?
Yeah, there is this constant ache, but then the same sharp pain will assail me when I try to bend. Lying down seems to help a little bit with the pain, but I can hardly lie in bed the whole day, can I? I tried a few things before coming in. So, first paracetamol and then ibuprofen and a heat pack. The usual go-to for anyone, I guess. That all seemed to help a bit, but not much.
Any other symptoms that you think might be associated with the pain, like weakness, numbness, or problems urinating or with bowel movements?
No weakness or numbness. As to the other symptoms, that's a no as well. I've had a bowel movement today. Also, no issues urinating at all. Basically, just this back pain, I guess.
And just a quick review of your medical history. You are on medication for high blood pressure.
Yes, lisinopril. I take it regularly. But surely my back pain is not associated with my hypertension.
We'll have to dig deeper. Any recent international travel?
Oh no, I haven't travelled out of the country for years. I mean, when would I have the time? I'm a lorry driver and I'm fully independent.
OK, Thomas. So let me tell you what I'm seeing. I could see as you walked in here that you were walking slightly stooped, likely due to the pain, and I can see now that you have some tenderness in the lower lumbar spine. As you already mentioned, there is limited range of movement due to the pain as well. But the good news is that there are no neurological signs. Due to all these, I would like to take a watch and wait approach at this time.
OK, what does that mean exactly?
Well, just to give it some time. This is the plan. For starters, a sick leave of at least 1 week is in order for you so that you can rest, which means absolutely no heavy lifting, please. And during that time, well, I'll send you for a physiotherapy assessment. Also, I'm going to prescribe codeine for the pain to help you rest. If things improve, then I would like to see you in 2 weeks. But listen, if the situation worsens, come back to me. In the meantime, I'm going to send off for some investigations that will help us if the situation does indeed worsen.
Do you think something else is going on other than just straining my back?
Well, muscular strain is a likely diagnosis based on the sudden onset of the pain and the lack of other types of symptoms. But if you don't feel better quickly, there are other diagnoses we need to explore.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You'll have the time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear part of a training about prescribing for junior doctors. Now read the question. This is an edubenchmark.com sample test paper.
So, in a previous training, we discussed the importance of prescribing in a patient care and how easily it can go awry. We also discussed medications classified as GSL, which can be used by patients without professional supervision, as well as POMs that can only be used under the supervision of a prescribing healthcare professional. So today we want to talk about the technical aspects of prescription. While there are some aspects that will vary from place to place, there are some elements that will remain the same, as these are required by national law. This is particularly true for products likely to be misused and that require extra controls to manage their supply. These products are known as controlled drugs and they are grouped into schedule from 1 to 5, depending on the likelihood for abuse as well as clinical application. This system is not to be confused with the class system used by the courts to categorise criminal possession of substances, which uses quite distinct criteria. So now,
Question 26. You hear a junior doctor asking about how to write a discharge summary. Now read the question.
hello Dr. Jacobs, could I bother you for a moment?
Of course, and it's not bothersome. So anyways, how can I help you?
Well, I'm working on the discharge summary for the patient in room 12.
The woman who presented to A&E with worsening shortness of breath and ankle swelling. Oh, that is quite a complicated case, so you have quite a task on your hands.
Yes, exactly. So I've written up the clinical details of her stay in the hospital, including any pending investigations, but I'm not sure how to proceed with the information for the patient.
And why is that?
Well, I'm struggling with how to include the key information about the patient's hospital stay.
I see. For this patient, there are quite a few investigation results, and including all of that information would be overwhelming. So I would focus on what the patient needs to do now. For example, what medication is she being sent home with? Also, what should she do if she experiences side effects? Also,
Question 27. You hear part of a conversation between nurses about a patient with dementia. Now read the question.
John, I don't know how you do it. I mean, you are so good with Mr. Allen.
oh, you'll get the hang of it. Communicating with patients with dementia and other cognitive impairment is a skill that you will definitely get the chance to develop on this ward.
Yes, and the population is ageing. So what do you do when a patient is confused? I mean, do you correct them?
No, because it's not really about agreeing with the patient. Take Mr. Allen, for instance. He is often very upset because he thinks he needs to find his parents. I mean, I know that his parents are not alive and wondering where he is, but trying to help him realize that will only lead to more anger. So what you need to do is validate the feelings and redirect.
Okay, so recognise how he is feeling, upset, and that it's okay for him to feel that way, and then continue the conversation about the topic I need more information about. That's a really good idea. I would never have.
Question 28. You hear part of a ward briefing on patient interactions. Now read the question.
So we have had a few negative interactions with patients and their families in the last shift. So I just wanted to review some techniques for communicating with angry patients and families. So the first is to adjust your style of communication. This includes keeping a calm tone and adopting a professional yet relaxed posture. Also, it is important not to assume how a patient is feeling, and instead let them know what you're perceiving so they can help to confirm or correct the emotion they are feeling. For example, you might say something like, "You're looking very upset by all of this," and sometimes the patient may say no, they are feeling frustrated, or that yes, they are very upset. This helps the patient to start to process the emotion and you to understand a bit more about why they are feeling a particular way. That way, you can make a more informed decision about what to say next to the patient. So,
Question 29. You hear a senior doctor discussing with a junior doctor how to interpret a test. Now read the question.
So, Dr. Holloway, we ordered a coagulation screen for the patient in bed 7.
yes, I'm a bit nervous because I know it's notorious for misinterpretation.
That is quite correct. However, if you understand the physiology of what is being looked at, it becomes easier to interpret. So, what is a coagulation screen checking for primarily?
Well, it looks primarily at the ability of the body to create a platelet plug and of the clotting cascade.
Very good. And what components actually make up the coagulation screen?
Well, there are several components, but the core parts include prothrombin time, activated partial thromboplastin time, bleeding time, and then thrombin time. Further tests can be ordered to work out exact pathology, but that would generally be in consultation with a hematologist.
That is right. So, with our particular patient, what are some coagulopathies we might expect to see in the screen?
So,
Question 30. You hear a doctor in the A&E talking to a medic about a patient with opioid overdose. Now read the question.
So, patient is showing several symptoms and signs of an opioid overdose: confusion, vomiting, pinpoint pupils, and then there are the signs of recent injection.
okay, so intravenous drug user. Can the patient talk?
Yes, patient is communicative, no signs of airway compromise. Respiratory rate is less than 12 breaths per minute. So, patient is at risk for respiratory acidosis and oxygen saturation was low. An initial dose of naloxone was administered in the field and patient quickly recovered. Patient then became verbally and physically aggressive.
Okay, any signs further doses may be required?
Not at this time, but
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear part of a training for junior doctors about explaining immunisations. You now have 90 seconds to read questions 31 to 36. This is an edubenchmark.com sample test paper.
So today we are going to talk about quite a daunting topic, explaining immunisations to parents. Before I get started, I want to preface this session by saying that it's going to be a quick overview of a general counselling situation. You will likely find yourself saying, but how could I possibly get through all of this in one visit? And the answer is you wouldn't be expected to. But it is better to be prepared to cover several different areas related to the central theme of immunisation in case they arise. These areas include explaining what immunisations are and why we do them, explaining the needs and benefits of immunisations, the process of getting immunised, as well as public perceptions of immunisations, such as the MMR scandal. So once you have established the reasons for a patient's visit to the clinic, you can ask the parent or carer what they already know about the vaccination programme, and just as important, what they want to know. Parents may have particular concerns regarding the vaccination programme, and being open to hearing these concerns is the best approach. Dismissing people's concerns will only lead to frustration all round. When you are explaining to patients' parents what immunisations are and why we do them, you should emphasise that the vaccination programme is very safe and that almost all babies have them. This segues into the idea of herd immunity, and that by stopping the disease from developing in one child, we also stop that child from spreading the disease. Another topic here are the short and long-term effects to a child of catching an extremely harmful disease. As you're explaining, be sure to frequently check for understanding by asking if everything is making sense or if they have any questions. Parents may also want to know about routine vaccinations, so it's important to have some understanding of each vaccine and the disease it prevents. However, it's also important not to bombard parents with lots of technical information and instead to highlight the key benefits. Routine vaccines that you should be familiar with include Bordetella pertussis, diphtheria, haemophilus, influenza B, HPV, measles, mumps, pneumococcus, polio, rotavirus, rubella, and tetanus. For each vaccine, you should know key facts, such as if the vaccine is live versus toxin, symptoms of the illness, complications, incubation period, as well as how the disease is transmitted and populations particularly affected by the disease. Once you've gone through specific vaccines that the parent or carer wants to know about, you can also explain to them what to expect on vaccine day, as this will help them to feel more relaxed about the experience as a whole. You should start off by saying that the practitioner will give the injection after screening for contraindications, which is done by asking about how the patient has been doing lately, whether the patient has started on any new medication, had any new diagnoses, or any allergic reactions. It's also necessary to explain normal reactions such as crying, irritability, and low fever, as well as measures that the carer can take, like ensuring the child keeps up their fluids. Finally, you need to cover the more extreme reactions that can occur, such as rashes and swelling, but this should be done with information about how rare they are. Another topic that may come up during the consultation is MMR and its link to autism. Our advice here is to explain the study that gave rise to this information and then the new evidence that has come to light since, without going into too many specifics unless there are specific questions. You might say that there was a piece of research published a number of years ago claiming a link between MMR and autism. However, since its release, it has been discredited. The research was on a very small group of individuals and the outcomes were biased by several factors. At the end of the consultation, it is recommended that you summarise the topics covered, including which vaccinations the parent is consenting to at this time. It is also strongly recommended to check parental or carer understanding to make sure there has been no miscommunication. You can also provide parents with an information leaflet on the relevant vaccinations and discuss the scheduling of other vaccinations. So now I'm going to take a few questions from
Now look at Extract 2. Extract 2. Questions 37 to 42. You hear an interview with Dr. Laura Sanders. an Alzheimer's researcher. You now have 90 seconds to read questions 37 to 42.
So I have here today Dr. Laura Sanders, a researcher interested in slowing Alzheimer's progression. So, Dr. Laura, is it fair to call you a comeback kid?
I don't know if anyone should call me a kid. And as for the comeback part, it isn't me that made a comeback so much. And it isn't me that made a comeback so much as it is the interest in this drug and its potential to slow the progression of Alzheimer's.
So, for our listeners who haven't heard about this drug and its history, can you please give us some background?
Of course. So the drug was shelved early last year by the companies developing it for what appeared to be lacklustre preliminary results. However, a more in-depth look at the data, as well as the incorporation of more data from 2 clinical trials, suggested that patients on the largest doses of the drug, aducanumab, did indeed benefit.
Can you give us a bit more information about these clinical trials?
Well, as I said, there were 2 clinical trials done at various sites around the world, including the US, Canada, Australia, as well as several European and Asian countries. Both were 18 months in length and randomised, double-blind, placebo-controlled Phase 3 studies, which are conducted to confirm and expand on safety and effectiveness results from early studies done to compare the drug to standard therapies, as well as to evaluate the overall risks and benefits of it. As for the population of the study, it included people with early Alzheimer's disease.
So, what you are saying is that quite a bit of time and effort had already been put into this drug when it was shelved.
Yes, that's right, and money, of course, on the part of the company developing this drug. But with any drug or treatment, years and years of research and trials are done before the public ever hears about it.
So, what was found exactly when the data was re-examined?
Well, people who took the highest amounts of the drug were found to have declined 30% less as measured by a commonly used Alzheimer's scale than people who took a placebo. These results have reignited research into the drug.
So, speaking of the drug, aducanumab, how does it work?
The drug is an antibody designed to target clusters of amyloid, which is a sticky protein that is believed to accumulate in the brains of people with Alzheimer's. I say believed because there are still some researchers that argue that the presence of amyloid is a red herring. But research on this drug showing that clearing the amyloid slows the decline of patients is further evidence of the significance of the presence of amyloid. Brain scans of patients who received the drug also showed less tau, another protein associated with Alzheimer's. No matter what ends up happening with this drug, it has definitely provided new evidence about the role of different proteins in the development of Alzheimer's.
And what about side effects? Is it true that doses were initially kept low in the clinical trials because of concern about possible side effects?
Yes, that is true, and as with any drug, there are some side effects. So, around 40% of people who received the highest dose of aducanumab showed signs of brain swelling or bleeding according to scans, but most didn't go on to exhibit any symptoms of those problems.
So, what do you think will be the final verdict on this drug?
Well, I think it's too early to tell just yet. I think one key lesson from all of this is that science takes time. We can't rush it. I know there are researchers calling the results exhilarating and an important moment for the Alzheimer's field, and I am also optimistic, but cautiously so. There are aspects of this study that complicate matters. As you mentioned in a previous question, there was a concern about dosing, which resulted in a change in dosing midway through the trial. And then there was the trial's early ends. Both of these changes further complicate the research and analysis. Those complexities and the whiplash they have caused have understandably left some researchers wary of these newest results. Personally, I am withholding judgment until more data is available. More independent analyses of the drug are needed.
It has been a pleasure.
That is the end of Part C. You now have 2 minutes to check your answers. That is the end of the listening test.